Hi, this is Pete here. This is the Q3 2016 drug chart pilot. We've changed our allergy section slightly to recognise that there are allergies and there are other reasons to avoid drugs, so both can be listed. If there are no allergies and no reasons to avoid drugs, then the doctor should sign here. Just a reminder that in order to unnecessarily use two drug charts, electrolytes can be charted on the last two pages of the chart as well as the front. While we don't have it here, when this drug chart is reprinted, we'll have a max dose of 400 milligrams of gentamicin. We have included double signature facility for nurses, should they desire. Based on our audit last year and national initiatives, we've included thromboprophylaxis decision support for medical patients and a flexible platelet criterion for withholding. Just in case you didn't hear us, we have thromboprophylaxis in here. And we've revised the 9-point checklist here with some new stuff. People are maybe on trials, they may be taking social drugs, and sometimes they're buying medicines over the internet, which we don't advise. Just to remind you, there's a 6-point checklist for warfarin for doctors to make sure that everything has been done to make sure that the patient has a safe journey while on warfarin in and outside. We've revisited the anticoagulation extensively with Dr. Gilmore. We're discouraging the use of prolonged BD dosing of low molecular weight heparin in non-valvular atrial fibrillation, as you can see here. We are discouraging the use of EGFR where there is no consideration for the patient's size or body surface area, and this is based on the latest clinical trials with DOACs. We are reminding you that there is now an antidote for dabigatran, which is available through the blood bank. We have included dosing information for all 4 DOACs, factor 10A inhibitors on this page, and we are reminding you about the new one, which we do not stock on all wards, and there will be a rationalisation of inventory management in this area. We are reminding you that regulatory data differs between the US and Europe, and to be very careful when prescribing drugs, particularly when you're not familiar with them, and give due consideration to drug interaction potential. The new DOAC also, you will note, requires low molecular weight heparin if considering using it for VTE, and there are concerns about the use of clarithromycin, which again may not be in the European data sheet but are in the US one. There is a generic drug interactions table here, and we remind you to make sure you check all regulatory information, and also we would advise, as you have free access, to use the up-to-date drug interaction facility available. Finally, our visual lesson on prescribing, reminding you that if a patient has no allergies and no drugs to avoid, to complete checkpoint number 3 on the front page. Reminding you how to prescribe flexible dose steroids, for example, and that when crossing out a drug, this is the only thing that really ensures that doctors and nurses do not restart a drug or inadvertently give a drug that has been stopped. Give a reason for doing so as well. And a reminder, heights and weights are absolutely required for patients on low therapeutic drugs, and we cannot treat sepsis, MI and clots without it. And that includes pain for simple things like IV analgesia.